Welcome to this clinical walkthrough on the severe depression with suicidal ideation case for the UKMLA. This is brought to you by Mediate, your 24/7 practice partner.
So here's what we're going to cover. We'll start by breaking down this high-risk scenario. Then we'll walk through how to take a focused history, justify your diagnosis, handle the crucial management and escalation, and finally, how to wrap up the consultation safely. All right, let's dive right in with the scenario. Look, this is a really high-stakes OSCE station. The absolute key to passing is recognizing how serious this is right from the get-go. Okay, so here's your patient. You've got a 20-year-old who you know has a history of severe depression. They've come in talking about a low mood, but here's the red flag you can't miss. They have active suicidal thoughts. That one detail immediately tells you this is a high-risk situation, and you need to act fast. So how do you handle the history taking? Well, in this station, you don't have time for a full psychiatric review. Your questions have to be direct and completely focused on assessing the immediate risk to the patient. You should always kick things off with a nice, broad, open question. Something simple like, how have you been feeling lately? This does two things. It helps you build a bit of rapport and it lets the patient open up, giving you a good baseline for their current mood. Now, this is the most important question you will ask. You have to ask about suicide directly. Don't dance around it or use vague language. A clear, straightforward question like this is your most essential tool for assessing risk. And right after you ask about thoughts, you have to follow up about intent. This question is what helps you figure out if we're dealing with ideation or an actual plan. The answer tells you exactly how high the risk is right now. A plan means the danger is immediate. Next, you need to check in on their immediate safety. Asking them directly, do you feel safe going home right now, is so important. Their own perception of safety is a massive clue for what you need to do next. And before you wrap up your history, make sure you cover these practical points. Do they have support at home? Are they taking their meds? Are they going to therapy? Knowing this stuff is vital for putting together your management plan. Okay, you've got the information, now you have to synthesize it and justify your diagnosis. This isn't just for the examiner. You need to explain your thinking clearly to the patient too. You need to state your diagnosis clearly. You can say something like, based on everything you've told me, it sounds like you're going through an episode of severe depression, and the thoughts of self-harm mean we need to get you some urgent support right away. And be completely firm on this point. The risk level is too high for primary care. This patient cannot be managed in a GP setting. The only safe option is immediate escalation. That brings us to the most critical part of this whole station, your management and escalation plan. This is where you really show that you can act safely and decisively to protect your patient. Your plan needs to have 4 clear steps. Number 1, an urgent referral. Number 2, a very specific safety warning. 3, explaining what happens next with the crisis team. And 4, just touching on the long-term support picture. This is the kind of language you should be using. It's direct, it tells them it's urgent, today, but also manages expectations by saying it's not an ambulance case. Then, it immediately moves to the practical step of how they'll get there safely. You have to say this. It's a non-negotiable safety instruction. The patient is not in a fit state to drive a car, and you must tell them that explicitly. It's really helpful to explain who they're going to see. It reduces their anxiety. Let them know they'll be seen by the Crisis Resolution and Home Treatment Team, the CRHT. Explain that this team will do a full assessment and decide if they need to be admitted or if they can be supported intensively at home. And finally, briefly mention the longer-term recovery plan. This shows the examiner you're thinking ahead. You can say that once things are more stable, the team will work with them on medication, therapy, and a crisis plan, and that you'll follow up with them at the GP clinic after discharge. Now is a good time to mention you can practice this exact case right now and get objective feedback on maced.com. All right, let's talk about how to wrap this up. A safe, clear conclusion is absolutely essential. You cannot let the patient leave your room without knowing exactly what the plan is and what they need to do next. So, think about it. After walking through all these steps, do you feel ready to manage this case safely? Knowing this structure is what will keep you confident and in control when you're under pressure. And remember, you can go and practice this exact case right now on mymediate.com.